Hi everyone, welcome back to the second part of this week lecture. So in this video, we will discuss of the pharmacological actions of sedative and hypnotic agents. The most common mechanism of action for sedative hypnotic agents is to enhance the inhibitory effect of GABA, which is the gamma aminobutyric acid in the central nervous system. GABA is the major inhibitory neurotransmitter of the brain. It actually occurs in 30 to 40% of all synapses, which is the second only to glutamate as a major brain neurotransmitter. So the GABA natural function is to reduce the activity of the neurons to which it binds, and it contributes to motor control, vision, and many other cortical functions. It also regulates to the anxiety. There are actually two distinct classes of GABA receptors, which are the GABA A as well as the GABA B receptors. They differ in the pharmacological, electrophysiological, and biochemical properties. Type A of the GABA receptors is ionotropic receptors that compose of 5 subunits of a ligand gate protein forming a pore selective to the chloride and ions. In contrast, the GABA B receptors is a metabotropic receptors that connected with second messenger system and exert a rather modulatory role in the central nervous system. Activation of these GABA B receptors open up the potassium channels, or it can inhibit the adenyl cyclase, which lowers the CAMP levels. In this sedative hypnotic topic, our main concern is more toward the GABA A receptors. GABA A receptors actually is a ligand-gated ion channel that located in your cell membrane that has important pentameric or 5 unit that arrange like a roselle that has 5 petals that surrounding its chloride channel in the center as a pore channels. So this pentameric glycoprotein subunit composed of 2 alpha subunits, 2 beta subunits, and 1 delta or gamma subunit. In between of the alpha and beta subunit present of GABA receptors or their binding site. Once the GABA bind to its receptors, it's allowing more chloride ion to enter to the cell, or known as influx of chloride ion, and can cause hyperpolarization that making the membrane less likely to depolarize, thus reduce the neuronal firing rate. So benzodiazepine and barbiturates require GABA receptors. So these benzodiazepine receptors or binding site located in alpha subunit of GABA A receptors. So once it binds to alpha 1 subunit receptors, they are responsible for sedative hypnotic as well as the amnesic agents. Once the drugs bind to alpha 2 subunit of benzodiazepine receptors, they can be responsible for anxiolytics. Meanwhile, alpha 3 subunits of benzodiazepine receptors are responsible for anxiolytics, muscle relaxants, as well as alcohol penetrating agents. As I mentioned before, benzodiazepine can cross the blood-brain barrier, acts very selective on alpha subunit of the GABA receptors. The binding effect of benzodiazepine is to enhance the response to GABA neurotransmitter by facilitating the opening of GABA-activated chloride channels. What it does, benzodiazepine, once it binds on the benzodiazepine binding site on the GABA A receptor complex, it enhances the receptor affinity for GABA neurotransmitters, which increase the frequency of channel opening, consequently increase in chloride influx in the neurons, which cause the hyperpolarization and decrease the neuronal firing. So they promote binding by increasing the frequency of chloride channel opening, intensifies the GABA effect but does not act as direct GABA agonist. So it will limit the amount of CNS depression by benzodiazepine. Barbiturates are an example of positive allosteric modulator for GABA neurotransmitters. It binds into a different site as compared GABA on the GABA receptor chloride channel complex. It will potentiate the GABA that induce chloride current that prolong the chloride channel opening, which allowing more chloride ions to enter to the cells. This will lead to membrane hyperpolarization that eventually cause CNS depressions. At higher dose, barbiturates mimics the effect of GABA and inhibit the release of the calcium ion-dependent neurotransmitters. As a result, barbiturates cause non-sedative CNS depression. For instance, it will result in inhibition of neuronal impulse in reticular activating system. As last week's lecture, reticular activating system is a set of connected nuclei in the brain that are responsible for regulating wakefulness and sleep-wake transition. Additionally, barbiturates also affect the cortex as well as in the cerebrum area that will result in affecting in consciousness, memory attention, thought, and motor output. So I can say that in general, barbiturate has several pharmacological effects, which are the sedative, hypnotic, anticonvulsant, as well as the muscle relaxant. Although benzodiazepines are considerably safer than barbiturates, they are not without their own side effects even in therapeutic dose. The most common side effect is development of drowsiness. It is because that benzodiazepine is a CNS depressant which can cause drowsiness and incoordination. And this situation can be worsened if combination with the ethanol, which ethanol is one of these central nervous system depressant too. Other than that, it will cause psychomotor as well as cognitive impairment, which lead to loss of coordination and decrease of attention. So, when you consult patient on benzodiazepine, bear in mind in these two adverse effects, you should advise them do not drinking alcohol, which alcohol can worsen the side effect profile of benzodiazepine. Besides that, you should also advise them to not driving while on this medication, which can cause them to lack ability to pay attention and focus, which can dangerous to him or also to the other people. Benzodiazepine also can cause anterograde amnesia, which basically the loss of the ability to create new memories after the event that caused amnesia, which is leading to a partial or complete inability to recall the recent happening. Aside from that, benzodiazepine also can associate to behavioral disinhibition, which basically the loss of restraint over some form of social behavioral lead to irritability, excitement, aggressions in small percentage of the benzodiazepine user. In acute overdose, benzodiazepines are considerably less dangerous compared to the barbiturates. It can cause prolonged sleep without serious depression of respiration or cardiovascular. Fatality are rare, however, when it combined with other CNS depressants such as ethanol or alcohol, it will be quite dangerous, which lead to severe CNS effect such as the respiratory depression, which eventually can cause coma and then death. In the clinical practice, if this case happens, first and foremost, clinician will provide airway or respiratory support and try to reduce absorption of benzodiazepine by giving the gastric lavage such as the charcoal. They also can initiate reversal agents such as the FLUMAZENIL, which is FLUMAZENIL is an effective benzodiazepine antagonist, which we'll discuss later. Before we discuss further about the FLUMAZENIL, I would like to highlight here that benzodiazepine also can cause or associated with the development of dependence and withdrawal. It can lead to the attribute to the effect through induction of hepatic metabolizing enzyme and changes at the receptor level with the chronic use of the benzodiazepine. Yes, if you compare benzodiazepine and barbiturates in terms of development of the dependence and tolerance, it's quite slower and lesser magnitude as compared to barbiturate. However, although it's lesser, it can cause the withdrawal effects. These withdrawal effects experience about 45% of the patient at low dose and 100% of the patient at the higher dose of benzodiazepine. So when discontinued suddenly, some of the withdrawal symptoms may occur. For instance, short-term use may cause mild anxiety, insomnia, tremors, and sweating. And for patients who are on long-term use of benzodiazepine, it can cause panic, paranoia, delirium, and seizure to them. If you can see here, short half-life benzodiazepine are associated with more acute and intense withdrawal symptoms compared to the long half-life benzodiazepine. So drugs with short half-life are cleared from the bloodstream fairly quickly and may induce withdrawal effects such as rebound, excitement, and insomnia. Those with longer half-life are cleared less quickly, resulting in a decrease in withdrawal effects. So the resulting slow drop in blood levels allow the body to have more time to adjust to the lack of drug more effectively. This is why short-acting benzodiazepine has more intense withdrawal than the long-acting. So if this phenomena occur, how we handle it? So benzodiazepine first. Benzodiazepine should not be seized abruptly. Second, if you want to stop it, you must gradually reduce the dose by 10 to 20% every week. So patients should be allowed to stabilize first between each of the reduction. And it is gradual step by step to prevent the benzodiazepine withdrawal symptoms. As compared to barbiturates, benzodiazepine are extensively used clinically, and there are several reasons for that. First and foremost, of course, the fact that benzodiazepine have greater margin of safety as compared to barbiturate with less adverse effects. Besides that, little effect on REM sleep. They have effect on hepatic macrosomal drug metabolism enzyme, unlike barbiturates that I mentioned earlier, that barbiturates are actually cytochrome P450 enzyme inducers. Additionally, it has slight physiologic and psychological dependence and withdrawal syndrome. FLUMAZENIL is the only member of the IMIDAZOBENZODIAZEPINE that behave as a specific antagonist of the benzodiazepine. So, in clinical use, FLUMAZENIL is used in the management of suspected benzodiazepine overdose, as well as in the use to reversal of sedative effect that produced by benzodiazepine that were administered during either general anesthesia procedure or during any diagnostic or therapeutic procedures. So how it does, it will attach to the benzodiazepine binding site, but it does not facilitate action of GABA. It actually antagonists of benzodiazepine binding site of GABA A receptor. Consequently, it competes with any benzodiazepine that is present, displace the benzodiazepine from the receptors, as well as reversing the action of benzodiazepine. So this is how FLUMAZENIL works as antidote in treating benzodiazepine overdose. You need to know that FLUMAZENIL is only available in the vial form, which can be administered through intravenous. It shows clinical effect within 30 to 60 minutes before eliminated almost entirely by hepatic metabolism to inactive products.